Well, good evening, Western Australia and other viewers. Welcome to session 2 of Polio Australia's 4-part webinar on polio survivors and their health conditions. Tonight's session is about post-polio conditions. You joined us last night for session 1. You would have heard all about polio and its survivors. It's certainly easy to participate in a learning event and then kind of move on, but my training is in education, and so I like to have people reflect on the things that they learn and they do. So we have the reflection form built in. We had some problems with that yesterday, but we got over that. So it's up and running. A part of that reflection form, there was questions about what did you find the most impactful from the last session, and then what did you do with that information? Did you share it? Did you write it down? Did you pass it on to someone who you think needed it, someone who might be particularly interested in it, or have some use for that information? What I want you to think about as we move through the diagnosis and clinical features of the 2 post-polio conditions. In this session, I'd like you to think what other patient population may benefit from some of the concepts we cover in this related to late effects of polio and post-polio syndrome, but possibly transferable to other conditions that you treat. It's easy to focus on conditions and diagnoses as health professionals, but during this session, I would like you to keep the context of the polio survivors we talked about in our last session, particularly their physical and environmental and systemic barriers and psychology that we discussed in the last session as we go through a more clinically oriented session tonight. So post-polio conditions. We're going to start looking at the late effects of polio, which we abbreviate as LEoP. And this refers to a myriad of symptoms that individuals with a history of polio may experience, particularly later in life, decades later, after a period of stability in their function. The features of late effects of polio can be considered in 3 broad categories. We're going to go through these categories of these features. But I just want to point out that the late effects of polio is a larger umbrella term to describe what polio survivors face in their later years. Just understand as well that when we're looking at either of these conditions, there's a lot of variability between polio survivors, what symptoms present and to what extent they present. An individual should be treated exactly as that individual with a very unique condition. So number 1 here, some things attributed directly to damage caused by the polio virus. Those features are things like the residual weakness, asymmetry in body, in limb length, pelvic obliquity, joint deformities, circulation disturbances that cause cold intolerance, and changes in muscle tone, a respiratory insufficiency, and those kind of things. Features related to the body's failure to maintain the level of recovery related to post-polio syndrome. I'll give you the example of motor units that we saw in yesterday's session diagram in the bottom left corner that showed the 2 nerve alpha motor neurons coming out to the muscle fibers One had been affected by polio virus and was white, and the remaining one, which was in yellow, was the surviving motor neuron, and that would adopt up to 8 times the muscle fibers that it was originally innervating. It's a body's way of compensating for neural loss. And it's interesting to remember here that loss of motor neurons is actually a feature of normal aging. We lose about 25% of our motor neurons as we age. In the case of a motor neuron that's under quite a lot of stress, chronic stress, where it may have adopted many local muscle fibers as a result of polio nerve damage. These nerve cells, these nerve fibers have to regenerate, and it's this regeneration that we think is part of the main profile of new weakness and changes in strength profiles of polio survivors, and as a result, feature of late effects of polio. So the body can't maintain that level of innervation. And when we're talking about motor units, we're talking about giant motor units that have a lot of muscle fibers to one nerve cell. We see that on EMG. We can kind of track things that way. But just keep in mind that this regeneration of a motor unit can fade and become slower and less effective as we age. The third item, features resulting from secondary trauma. These are things like repetitive stress injury from having dysfunctional movement for decades. Things like arthritis developing in a lower extremity, ankle or knee joint from dysfunctional motion. An example fairly common is chronic use of a wheelchair or crutches, causing carpal tunnel syndrome or shoulder dysfunctions. On the Polio Australia website, we have a fact sheet about the late effects of polio, and this is taken from the bottom half of that sheet. Some of the top items we've discussed last session and already this session. So I'm going to kind of head down towards the Boggle Features in the bottom right corner. Again, a part of this education and series is to help you understand that polio is not simply a disease of paralysis. But there's a lot more going on here than just paralysis, even though that is a vital key element of surviving polio. So looking at the Boggle features, impaired thermoregulation or decreased regulation ability. This comes back to the tone of the circulatory system and maintaining even, consistent temperatures across limbs in the body. And this is not merely a subjective, the limb feels cold to the polio survivor, but it actually does feel tactile, a different temperature compared to other limbs. This is particularly important to keep in mind for those polio survivors who have surgery, because the temperature of the operating theatre, the length of time a limb may be unprotected or not kept warm, and then the recovery process from anesthesia can also bear down on be affected by the ability to maintain warmth in limbs. Dysphonia, dysarthria. Now these are related to motor function. Small muscles that drive speech or small muscles in the neck area also drive the swallow functions. And it's easy to overlook these smaller muscle groups when we're easily visually attentive to larger muscle groups and larger movements of the human body. I was talking to a polio survivor just yesterday, and we were talking about weakness and changes in muscle. And I brought up this point that there are a lot of other smaller muscle groups we take for granted, in particular the voice and swallow ability, and these are quite important. I said, we have polio survivors who can't hold long conversations, can't do long phone calls because their voice kind of weakens and fades out and may become unclear in terms of the quality. And this gentleman had a very strong voice, but he said, actually, that's interesting to note because I do have these episodes of my voice just failing and just being unable to speak. We need to keep these bigger picture factors in mind. The third one I want to mention here is the chronic fatigue. We have central fatigue coming out of the bulbar area, mechanisms there. And we also have peripheral fatigue, where we may use a limb or a muscle group and that limb gets tired. So this fatigue is particularly relevant because while there aren't usually any cognitive deficits from having had polio, there can be apparent ones. Someone who has sleep difficulty and chronic fatigue and this central fatigue, it can cause difficulty for them sustaining attention, have less concentration, and so it looks like there may be an impairment. But we know that if they're recovered and they're not as fatigued, their attention and concentration is quite normal. So it's phasic and related to fatigue. So under that umbrella of the late effects of polio is a more specific actual diagnosis called Post-Polio Syndrome, known as PPS. And this is classified as a neurological disorder, though not purely neurological from what we've already seen in the last session today. So it's not a real neat fit into that disorder group, but mostly fits quite well. Diagnosis is based on 5 key indicators. So late effects of polio isn't actually a diagnosis, it's more of an exclusion of other conditions that the patient may have and other reasons that they may be having these symptoms, and we could say, well, these are probably the late effects of polio, let's treat it as such. Post-polio syndrome is an actual diagnosis, ICD-10 or 11 code. Specific. I'm going to go through those key indicators, but it is worth noting that an estimated 40 to 70% of people with late effects of polio will develop post-polio syndrome. We're going to look at that in a few slides. And also on the next slide, we're going to talk about how the onset of post-polio syndrome and how it's precipitated and the risk of developing it if you have had polio. But back to the diagnosis and the 5 key indicators. Some of these are quite oriented towards weakness and muscle function. And that is one of the criticisms of this diagnostic list. It's a tool that we use and the best tool we have for diagnosing post-polio syndrome. I wouldn't call it a gold standard, I'd call it our current standard. So number 1 on that list is a history of polio, having some weakness, and this weakness may be confirmed by use of EMG. Already you can see that a history of polio, some people may not be able to express that or confirm that for going through this diagnostic process. But by the time we get to an EMG, we can certainly get some level of confirmation and confidence that it may have had polio. Item 2 would be recovery from an acute phase of disability or paralysis, followed by a stable period in their life. Number 3 is the onset of new weakness. Number 4 is a greater than 1 year period of having this change and these new symptoms or new loss of function. And then number 5 is exclusion, similar to late effects of polio. We try and exclude everything that else that could be a reason for the symptoms this patient is presenting with. So post-polio syndrome is usually diagnosed by a rehabilitation physician or a specialist, a neurologist, not usually your GP. You would go to a clinic and maybe get assessed. In Western Australia, there's the Fiona Stanley clinic is one that stands out. And on the Polio Australia website, you can look at the list of clinics still operating across Australia. If you had a patient that you think needed a closer look and referral to a clinic, you can see that list on the website. So talking about tools and post-polio syndrome, it's a good idea to think back to manual muscle testing and muscle charting. And the development of that tool actually occurred during the polio epidemics because we needed a way to determine what was the level of weakness and paralysis. We needed to work out what the benchmark was going to be for admission to a hospital and that kind of thing. And we know that that tool, muscle charting, is not perfect. And it has a ceiling effect at the level of 5. Some inter-rater issues, but we know that it's the best tool we have available, so we continue to use it, and it is certainly useful still, as opposed to more complex and expensive test methods. In that estimated 40 to 70%, I'll just make a note that in our survey that we ran at the turn of this year, the respondents were 50-50 of those who had an actual diagnosis of post-polio syndrome versus those who didn't. So the precipitation of post-polio syndrome and some risk factors, there can be a gradual onset or it can be precipitated by the following stresses. So physical and emotional stress, chronically, a health event or a medical event. And this may be your first encounter with a polio survivor. They may actually be hospitalized or be needing health care because they had a severe case of flu, they had a fall, they had a fracture, and they're having difficulty bouncing back from that. If you think back to the chart on the previous session last night, you remember that diagram that had the health events and the level of function compared to time. And this is that second arrow from the red second health event, where the trajectory was slower and wasn't as a distinct return into ease of function or normal function. Some polio survivors may come to you and say, "Hi, I had polio. I need some treatment. I need to address these issues." But many you'll come across in the course of your work that have knowledge that they had polio and need to appreciate the impact of late effects of polio on their other health conditions. Risk factors, these were outlined by Dr. Laura Halstead out of the United States in his book from 2006, Polio infection as an adult, not as a child, hospitalized at onset, longer time since onset, laborious work history, meaning that you had a very high physical chronic stress in your work history. Those factors together increase the person's chance of developing post-polio syndrome. Now, in addition to these items, in the 2001 Queensland Health document titled Late Effects of Polio for General Practitioners, they highlighted a few others, one being the level of residual impairment from the original polio, weight gain, muscle pain with exercise. So we may get muscle pain after exercise, DOMS effect, that kind of thing, if there's strenuous exercise. But muscle pain with exercise as a regular response to exercise was an indicator in one of the studies they analysed in their document. Weight gain is also something that's important to monitor for polio survivors, because if we have increased weight means increased loads on limbs and increased loads on bracing and calipers and support devices. But yes, weight gain can also be a factor in precipitating PPS. Yesterday we looked at the percentages of those who had the polio virus who either didn't show signs, they were asymptomatic, versus those that had characteristic paralysis. And in between, we talked about how there were some that had mild flu symptoms, which would be the uncharacteristic signs of disease. That's at the top of this slide. And then those that had relatively characteristic signs of the disease, they had some kind of bulbar signs or some mild paralysis. So we have the 1% there versus the 92%. You can see that the second row of boxes, that the risk increases with the increased severity, which follows the logic of the previous slide. Look at the 1% paralysis, they also have considerable report of breathing disorders, sleeping disorders, and dysphagia. When we talked about those that had been exposed to the virus and developing post-polio syndrome, the risk here shows 20%. So let's just break this down a little bit. If we had a community in which there was an epidemic and we had 5,000 cases or 5,000 infections in that community, 50 of them would have paralysis, and they'd probably be hospitalized and go through rehabilitation. That would be the 50 on the far right side. But 80% of those, decades later, would present with post-polio syndrome. So about 40 of those 50. We'll move over a level to the relatively characteristic signs of disease and the post-polio syndrome risk of 40%. 40% of those 1%, which is 50, equals about 20 people developing post-polio syndrome decades later. So far, we have 60 out of 100 who have a higher risk of developing post-polio syndrome. But if we look at that 92% that did not have signs of disease or asymptomatic, and yet 20% of those are at risk of developing post-polio syndrome, that comes out from our 5,000 to be just under 1,000 cases, 1,000 individuals who may have moved elsewhere with their work or their life and to different regions in Australia or overseas. They may have come from overseas. And be very unaware that they carry this risk with them, having been exposed to the polio virus when they were younger. This is a point just to emphasize that, yes, many of those who had the acute paralysis, hospitalization, and had that duration, maybe a laborious work history, their risk of post-polio syndrome development is quite high, but there are many others out there who may be displaying milder symptoms who are actually showing post-polio symptoms, late effects of polio symptoms, and they go undetected. And this can serve to explain some cases that you may have experienced where there wasn't anything definitive and multitude of tests didn't pin anything down, and things came back unconclusive, and you got frustrated and your patient was frustrated. It may be worth looking back on those cases and thinking, hey, did I miss something here? Could this have been a good fit for what we're looking at in today's session? Both late effects of polio and post-polio syndrome, if we look at the physiology a little closer, Polio versus aging, we had that chart I was referring to moments ago with the two health events. That showed that top grey line was the 1% per year for non-polio in terms of change. And that grey line is derived from this finding. The first one, which is rate of reserve capacity decrease, is double the normal population. So the mean rate post-polio is about 2%, which is double that of the 1%. Reserve capacity refers to systems, body systems, ability to adapt and respond to flux in strain on the system. The easiest system to think about is obviously the muscular system, but you can think about a respiratory system, cardiovascular system. If we add strain and we don't have much capacity, much buffer to absorb strain or increase load in the system, then we can't respond and we'll suffer resistance in our system that may present as discomfort or fatigue or other responses. When we have quite a good reserve capacity, we can really have a lot of flux in the strain on that system and barely notice it. The second item I'm going to point out here is osteoporosis. Up to 96% in one study had osteoporosis or osteopenia. In the normal 80-year-old women population, 40% of non-polio women would develop these two conditions. But up to 96, I believe this was men and women were included in the post-polio figure. The low end of the number was 48 or 50%, so it's quite a significant amount. And I think even the baseline was above the 80-year-old women norm of 40%. There are obviously reasons behind why this number is so high in this population, and that is because the youth, when these polio survivors developed polio, they were in their childhood, and it's in our childhood and teens that we get that impact and that repetition that our bones need to develop that density that we carry with us for the rest of our life. And so not having that level of activity and impact or ability to move confidently or freely on a limb will certainly affect the ability of the body to lay down that bone density at that age. Obviously, there's a red flag here for fractures for their survivors, and knowing that somebody who survived polio may have great asymmetry in their limbs, leg length discrepancies, weakness on one side, asymmetry in general in their presentation, that falling is quite a common thing. And we'll look more at the rates of falling in the Information for Allied Health practitioners, which is the fourth webinar in this series. But we certainly need to keep that in mind with our polio survivors. The last one I'm going to point out here is the functional level is at a higher anaerobic threshold. So the baseline when functioning for polio survivors, doing their regular activities of daily living, the ADLs, can be actually close to anaerobic threshold. So if you think about if you've ever participated in track and field, and you know that the 400-meter race, it basically pushes you to the threshold, sustained sprint that puts you into that lactate zone. Imagine that just doing your usual ADLs puts your body near that zone, and you go into debt there. Means that basically for our polio survivors, we talk a lot about pacing, planning their activity, taking scheduled breaks, having a strategy for how they're going to perform activities, and then what they're doing socially so that they don't have big changes in their fatigue levels, and they can complete tasks confidently with greater independence. So we've brought up a lot of symptoms and complaints that you would find. So glance over this word cloud. Obviously, pain, weakness, and fatigue stand out as some of the most distinct complaints and symptoms that polio survivors have. And so when you're encountering polio survivors or kind of keeping the radar on for whether a particular patient may be a polio survivor, you know, think about these things, listen for these variables, these factors, and what would these things look like for this person. We need to consider the scope of these aspects related to the condition that they may have on our list of potential conditions. We need to also consider that there may be overlap of these symptoms into other conditions. Some of these symptoms are inherently a little ambiguous in their presentation, and it can be quite easy to misattribute symptoms to other conditions. So one way to avoid that is to simply ask, did you have polio as a child? Now, the patient may or may not know. So if they don't, the next level of question would be, did you live in an area that had a polio epidemic? We can find that out if they are unsure. Their childhood travels or movement as a family. They may have friends or family or a spouse that could answer that question. But we can also look this up in public records for where the epidemics took place as well. So a lot of items there to consider in terms of what might present, what the patient may say. Those who have post-polio syndrome and have been treated for it previously will likely speak quite fluently to many of these factors because the average polio survivor is quite well read on their condition and the history of polio. Again, one of the results from our Polio West Australia's survey in 2013 was this chart, which looked at the most common complaints, symptoms experienced by polio survivors. If you remember, we talked about this in the last session. There were about 1,200 respondents. Most of those, I believe it was about 900, were from Western Australia, but you can see there was enough from other states to be represented on this chart. We can see weakness, pain, breathing, difficulty, and sleeping. Now, it's interesting to note that in the raw data, sleeping actually sleeping difficulty outranked these other complaints. And the percent shows the percent of respondents who selected that complaint and symptom as problematic. So sleeping, anyone who's been a parent has probably experienced sleep difficulty. And there are many reasons for having difficulty sleeping, and many adults have difficulty sleeping. But what we do have to understand here is that polio survivors can also have difficulty sleeping for the same reasons that an unaffected person may have, but they also have some other factors that underlie the problem. Weakened respiratory muscles, scoliosis, kyphosis, asymmetry of the chest wall, chronic fatigue, central fatigue, complex pain, joint pain, cold intolerance. Now these things add a whole new level of sleep disturbance beyond what the average person would ever experience. So it's worth noting that when it comes to the complaints of fatigue and sleep difficulty, We need to see if we can help polio survivors improve these things for their quality of life. We saw quite a few symptoms listed in that word cloud, and those are not all the symptoms that humans can have. And so we also have factors that are unrelated to late effects of polio. So if your patient's complaining of these things as well, you may need to look elsewhere for what condition needs to be treated. Resting tremor, worsening peripheral neuropathy. So they have a peripheral neuropathy and it changes, it gets worse. That is not late effects of polio. Dizziness, vertigo, problems with sensory organs, eyes, ears, smell, that kind of thing. Numbness is not a usual symptom of late effects of polio, and primary altered sensation. Now, on this last one, it's interesting to note when I was doing my training in California, one of my clinical experiences was out at Rancho Los Amigos in Downey in California. That's where Dr. Jacqueline Perry, a notable rehabilitation physician, spent most of her career there, I believe. And she was there running the polio clinic when I was a student. One of my lecturers at university said, when you see Dr. Perry, ask her about polio and sensation. And so I thought, well, it's going to be interesting. I'll make sure I'll ask her. And so I did, and she did point out that what she knew and had seen in her experience, that while the virus entered the central nervous system and the spinal cord and it affected the anterior horn of the spinal cord, there was no reason to think that it also didn't infect the dorsal horn, and that it had some effect with some patients on their sensation. And she said, while it is not normal, when there is no other explanation, she said it was reasonable to assume that the sensation alterations may be attributed to the history of polio. Again, this is not a usual presentation, but just because someone has altered sensation doesn't mean that they do not have or cannot be late effects of polio. One clinical rule or tool that we can go by is Occam's razor. When we look at this cluster of symptoms, that which requires the smallest number of assumptions is usually correct. So if we have a patient in front of us and they are reporting a particular symptom, and we'd say, well, we'd have to assume that you had polio, we'd have to assume X, Y, and Z. Then we'd say, oh, well, this is attributable to late effects of polio. However, if there is a more straightforward reason, which requires maybe only one assumption for the symptoms to fit that condition, then this Occam's razor says go with that least number of assumptions, because that's probably going to be the correct condition with the symptoms to. Different studies across the world have asked polio survivors functional questions, and the Polio Western Australia survey was no different, and it came to similar conclusions, and that mobility is certainly increased with the late effects of polio and post-polio syndrome. Changes in mobility, fatigue with walking, difficulty with transfers, falls, tumbling, tripping, stair climbing, very commonly reported as changing, dropping things that are held, and having recent weakness. It's important to point out here, atrophy of muscles seems a little bit out of place. However, when you think about those who use bracing and calipers and supports on their limbs, there's a change in volume of the limb, whether it increases or decreases, and the fit of that brace or caliper changes, it changes the dynamics of how you use it and affect your stability and increase your fall risk. So noticing that your muscles are atrophying because of the fit of your long-term brace or caliper is certainly something that a polio survivor would notice. If you think about amputees and trying to get their prosthetics to fit, limb volume is very important to be able to predict and maintain and manage when you're wearing a prosthetic. The main point here for this slide is actually to pull us away from symptoms and look at what effect those symptoms have on function. We consider how we treat pain or a laxity in a joint. Does that affect something that you do? Does it affect function? If it doesn't affect function, we certainly need to consider how we're going to treat it. But those symptoms that clearly affect function and quality of life are the ones we should start addressing. This also gives us some clues for physical assessment and how we look at, particularly from the allied health perspective, with a polio survivor, what kind of tests we should run with them. So this is basically reaching the conclusion of this session. The next two sessions, which are the same time in your area and the same days of the week. The third one is information for medical practitioners, and the fourth one is information for allied health practitioners. Scan down the two lists here and see that they're quite different. I spent 10 years in a rehab hospital in Colorado, and one of the things I really enjoyed about that setting was that I got to hear and see how other health disciplines interacted with a patient with a certain condition, the advice they gave them, how they referred to them, how they educated the patient, how they operated within their scope of practice. It gave me a really good, thorough, broad view of how to deal with these conditions, how to advise patients that I had. So you learn a lot from listening in to what the education is for other practitioners. So I strongly recommend that you join us for both these sessions next week. I'm going to have a glance now at the feedbook feed to see where we're at with any questions being posed. Like we have none at this point. Please fill out our reflection form. Even if you watch this at a later date, that form we're going to leave online to get a sense of how people responded to the information and what they did with that information that they picked up. It's always useful to get this reflection happening as an educator. I want that reinforcement of something that you've picked up or heard or learned, so that you can kind of be the building block for the next level of your education. This series is certainly a foundation on the topic of polio and its survivors, polio survivors and their health conditions. And I pointed out that document by Queensland Health from 2001, Late Effects of Polio for General Practitioners. That would be a good next step to read that document. It goes into a lot more detail, and it's very broad in what it covers. We have resources on the Polio Australia website, polioaustralia.org.au, and that's mostly for the survivors. But there are fact sheets on elements of the conditions that I touched on tonight that are useful for both clinicians and for polio survivors. poliohealth.org.au is our website that is specific to health providers, healthcare workers, so we can find other documents related to polio survivors going through surgery, about late effects of polio. We have a Polio Australia manual, overview of polio and post-polio syndrome and that kind of thing. So have a look around. Sure to find something that can fill any gaps you have. My email is on screen here. You can always email me as well with questions, and I can point you towards some resources if needed, or answer any questions that you may have encountered clinically with a polio survivor. Happy to help you out with that. But until next week, enjoy the weekend, and we'll see you next week for 3 and 4.